Good evening, everybody. Wolfgang Hintringer is from Austria, and he's going to tell us a little bit about scaphoid nonunion. What is more important, stability or vascularity? I would like to thank you very much, Wolfgang, for joining us today. Wolfgang is the previous president of IBRA, so a person who is a long journey with us in the International Bone Research Association, and I'm quite happy that you're here today. Thank you.
Okay, thank you for your introduction. Good evening, ladies and gentlemen. I will talk about scaphoid nonunion, what is more important, stability or vascularity. And I want that you talk with me, that you ask me questions and stop me if you think that you want to know something what I tell you. But I want to have a conversation with you and not only a single conversation with me alone. Now I'm on the presentation. I want to begin with biomechanics of the scaphoid as introduction. So my first question is, you can see here a lot of not so good things, why it is so difficult to put a screw in the right place in the scaphoid. You see here one in that direction, one through the trapezium, one very diagonal, one very short. I collected a lot of such failures of scaphoid screwing. And one is for sure, the scaphoid has a difficult anatomy. It has, as you can see here, a spiral form. It is distorted in 3 dimensions somehow. And well, that's not so easy to get here a corridor in this spiral shaped bone. And one more, the scaphoid has a very different form in different individuals, and that makes it more interesting to get in that bone. The scaphoid, as you can see here, we have here that scaphoid is moving in a 3-dimensional fashion. That means it makes a flexion, rotational, translational movement. That means a movement in 3 dimensions. And that means if you want to put in a screw and you change your position of the scaphoid, you get always another bone for fixing it. And here you can see the small corridors from proximal and distal for inserting a screw. And once you have a screw inside and that does not work or it went wrong, then you have the second problem, maybe to change that screw or to put something other into the scaphoid. The scaphoid is together with the lunate and triquetrum a part of a variable geometrical condyle and a linking system between the first and second carpal row. What does that mean? You have here radius and ulna as an uninterrupted articular surface, and on the other side, on the other hand, you have here the distal carpal row, which is a monolith and has no motion, and the proximal row is a variable geometrical condyle. It can move with some movements between SL and LT and adapts in every position to the other partner on the distal and proximal side. And if the scaphoid, and here you see again that the scaphoid is moving more than the lunate stops and the scaphoid is moving first dorsally and volarly. And then if you fall on your outstretched hand, the scaphoid impacts on the dorsal side and the ligament resists. If the ligament resists the tension, you get radius fracture, or you get SL ligament disruption, or you get, depending on the forces on the direction, scaphoid fracture. And you can see here clearly how the dorsal impaction produces here on the volar side this scaphoid fracture. and the movement of the second row is contrary of the movement to the first row, and the proximal pole follows the first row, and the distal pole follows the distal row. And what does it mean? The carpal bones are a closed ring, and if this ring is broken, the scaphoid tends to flex and the lunate tends to extend. A rotational DC deformity occurs. You see here how this DC deformity with this rotational deformity occurs. And the same is not because of a ligament rupture, but also because of a fracture within the ring. This ring can, so to say, break. And you can see here clearly
die Gelenksflächen.
we have a bone here inside. The distal pole follows the distal row, and the proximal row follows the proximal row. And that means when you have here a constant motion between the two poles, you get here nonunion. You know all that linked articular chain system, which was described by Lambrinuti at 1943. And Lynchard and Dobbins described it in 1973. They were speaking about an intercalated segment, and that is stable during traction and unstable during compression. And the linking system between the capitate and the lunate, which is quite unstable, is this ligamentous connection to the STT joint, the scaphoid. And it's clear when this scaphoid breaks, that linking system does not work anymore. And here you see the fracture, and when this fracture is not stabilized, it comes to a non-union, and later on, because of the acting forces, to a humpback deformity, and you get not only a dislocation in one plane, but also a rotational deformity between the proximal and distal pole. And the question is, why is that so? Beneath the translational movement in the side view, you see here extension and flexion of the scaphoid. Look at the dorsal pole, which is translating out to the dorsal side. That is a needle in the STT joint. You see here now the extended scaphoid and now the flexed scaphoid. But what you don't see, I will show you in that video. We open the joint between the metacarpals and the distal carpal row, so that you have a clear view in an axial view here on the second, and here that is the first row, and here that is the second row. And look what's happening between ulnar duction and radial duction, and also flexion on the extension. We get here a rotation between the two rows, and that means if the scaphoid is fractured, the distal pole follows the distal row, the proximal pole the proximal row, and there is in between this ulnar duction and radial duction a rotational deformity. And so some scaphoids have also this rotational deformity, which is very hard to see in normal X-ray, but also in CT scans. So, and the question is, what needs stability and vascularity? What is more important? There are two parties of investigators, the stabilizers and the vascularizers. Who wins the run is the question. As you know, the blood supply comes from the dorsal side. The proximal pole is generally deemed by most investigators to be the main indication for vascularized bone grafting. In clinical practice, the term avascular necrosis is used for a wide spectrum of conditions of assumed circulatory compromise. Well, we have to discuss that that sentence, and we will see later on what does that mean. And so you can see here in 2019, Schneider, Renzig, Schmiedele, Scott, Wolf brought out a paper, does anyone need a vascularized bone graft? And I was on the ASSH this year in Las Vegas, and that paper was a big discussion between the plastic surgeon who tends to make vascularized bone graft and the trauma surgeon who tends to make no vascularized bone graft, more or less always only cancellous bone grafts. And so many hand surgeons argue that vascularized bone grafting is indicated in proximal pole avascular necrosis, prior failed surgery, or long-standing non-union. That is written in the paper, and a lot of people follow that sentence. Yeah? But there is no evidence to show significant differences in union rate or time to non-union between vascularized and non-vascularized grafting. That was the succours of this paper, and there is a big discussion if that is true. Yeah? Current diagnostic tools do not accurately reflect proximal pole vascular status and may blur outcome from comparison between vascularized and non-vascularized bone grafting. And the guys from Austria, from Innsbruck, they made two important papers, and the papers are correlation of CT imaging and histology to guide bone graft selection in scaphoid non-union surgery. And the second one was time-dependent changes in bone healing capacity of scaphoid fractures and non-unions. What does that mean? They were looking for CT parameters to identify the vascularity of a non-union scaphoid, and the CT parameters of bone structure and fracture location can reflect histological healing capacity of scaphoid non-unions. This can guide bone graft selection in scaphoid non-union surgery. And we will look which are these parameters. And they did in scaphoid non-unions preoperative 2D CT reformation of 29 patients. They were analyzed for trabecular structure, sclerosis, and fragmentation of the proximal fragment. And then they did a 3D CT reconstruction, grouped it in 3 zones, depending on the potential blood supply. And the CT findings were compared to bone healing capacity, age of scaphoid non-unions, and time to non-union. And how did they do that? The 2 CT parameters were trabecular structure, sclerosis, and fragmentation. And you can see here the type 1, presence of trabecular structure, absence of sclerosis and fragmentation. You can here clearly see in the CT scan that the bone has still a trabecular structure. In type 2, you have still a trabecular structure, but you have already a sclerosis, but you have no fragmentation. Type 3, you lost the trabecular structure, you see a dense bone, you see sclerosis, but you don't have fragmentation. And the type 4 is you have no trabecular structure, sclerosis, and fragmentation, the worst case of all. And they compared these 4 types to histological parameters. In type 1, they found out in the histology that blood vessels, they had blood vessels, singular erythrocytes, osteoid active tissue. In type 2, connective tissue with densely packed cell nuclei and collagen fibers, thickened trabecular signs of active tissue. the Azan, the Mallory-Azan Färbung. And in type C was a dense sclerotic area, few nucleo osteoclast tissue with less biological activity. In type 4, the cartilage shelf sparsely tubercle with huge empty spaces in between, reduced viability and disintegration of bone structure. And together with these 3D findings, and they described here the red zone, that is a very good vascularized zone. The red-white zone is in the ligamentous insertion of the SL ligament, some vascularity, that means red-white zone, and white zone, it's proximal to the insertion of the S ligament with no vascularity. And then they formed their classification. That means in type 1 and type 2, where you have clearly visible bone, clearly visible structure of the bone, they need no vascular bone graft. In the type 3, where you have, well, still a little bit structure, but in the white zone, a vascular bone graft, in the red zone, a non-vascular bone graft, and only for the fragmented type, it's clear you cannot put any screw or something else in it. They voted for an osteochondral vascular bone graft from the knee joint, a combined graft from cartilage and bone. Well, and in their paper, they suggested that a growing body of evidence suggests that histologically defined proximal pole avascular necrosis can be successfully treated with cavitation of necrotic bone, non-vascularized bone graft, and rigid screw fixation. And the authors recommended standardized reporting of proximal and distal pole vascularity, vascular assessment modality, preferably histological quantification of necrosis of CT trabecular structure, proximal fragment size, structural defects and fixation methods in future studies, comparing reconstructive techniques. These considerations will help better define which scaphoid non-unions may benefit from vascularized rather than non-vascularized grafting. What does it mean? That we have a lot of different non-unions which are all put it together in different studies, and nobody knows which kind of fixation did they do, which kind of vascularized bone graft they put it in the hole, and did they good carpentry or bad carpentry, and there are such a lot of things which cannot be compared. And well, we will see if in the future we get better papers which we can compare. And that leads us to the method we use in scaphoid non-unions. So I have to change my presentation. And that's getting interesting for you, because that's what I told you till now. It was a lot of theory, but helpful theory to identify which scaphoid should be operated with non-vascularized bone graft and which with vascularized bone graft. Is there any question from you till now? You can write me something on the screen or ask me. I see here no microphones are on. I'm alone here and nobody wants to talk to me. Well, then I will.
There's one chat.
Yeah.
Why did they only use VBG from the knee? Is a question from Inga.
Yeah. Well, yes. I will explain it later on, because we used before also vascularized bone graft, like from the volar side, Matula, or on the dorsal side, Seidenberg, yeah. But I will show it in that presentation that we don't use these methods anymore, because we use only vascularized bone graft in fragmented proximal pole fractures, and there the Seidenberg cannot be used, the Matula cannot be used, because you need a combined vascularized bone graft with the cartilage and the bone. Yeah, why not from the radius? I can see that. Yeah, because that brings nothing if you have a fragmented proximal pole. And in all the others, you will see that in that presentation, we don't use any more vascularized bone graft. Also, not from the radius, and we even don't use vascularized bone graft from the knee joint alone, bone vascularized bone graft, only combined ones. Okay, any other questions? So again, this question, is that for sure that if we have a dense proximal fragment, a MRI with signal loss in T1, the scaphoid has no blood supply or is avascular? Most of the people say, if I have in MRI a signal loss in T1, then I have an avascular situation and I need a bone graft. The question is that true? Or do we need in every case, if it is suspicious that the path of the scaphoid is avascular, a vascular petechic graft? Is the healing rate of vascularized graft higher than other methods? What is more important, vascularity or stability? So I ask you, what do you think? What is more important, vascularity or stability? Write it in the chart, or both. Stability. Okay, that's good, because that's what we intend to do, yes. Because we think if we give the bone a lot of stability, and the stability is held over maybe months, then also avascular fragments can revascularize. So here are some papers. Does anyone need a vascularized bone graft? Conclusions from Renzi and the Hand Clinic. No evidence for better healing with vascularized graft. Current diagnostic tools are unable to reflect vascularization of the bone. There is the question again, if we have also in the MRI a black gadolinium MRI, a black proximal pole, does that mean it has no vascularity? I don't think so. Treatment of scaphoid waist nonunion by 1, 2 headless compression screws or blade with or without additional extracorporeal shockwave therapy. The Quadlbauer and the colleagues of mine in Vienna, they found out we need more rigid fixation, and they did shock waves, high energy shock waves, and they had also an additional healing effect. Then here, Matsuki in 2011, a non-vascularized iliac bone graft with Herbert type screw fixation obtained satisfactory clinical and radiographical results. Well, that is a little bit too simple for me, because there are different types of non-unions, and I think that's not really described in that paper. And Cohen wrote in 2013, with stable internal screw fixations, scaphoid waist non-union with collapse and bone loss can be successfully treated using only cancellous bone graft. And here TAMP 2006, 11 patients with long-standing non-union were treated with vascularized pedicle bone graft. Only 6 of the 11 non-unions were united. That's a very negative outcome here in vascularized bone graft. Here another paper from Megale, German colleague, no significant correlation in correlation of diagnostics, preoperative MRI assessment of vascularity and union, and Sink in 2004, enhanced MR assessment of the vascularity of the proximal fragment of the scaphoid non-union do not accurately predict the outcome, or poor MRI proximal vascularity is not an important determinant of non-union. What we have seen is that if we open up, even when the MRI suggests there is no vascularity, we find blood points in the vascular, in the proximal pole, if we have structure in the CT scan. And so this contribution of vascularity to healing is unclear. And it is even more unclear if the vascularity of the scaphoid or the graft is more important. And there is no information if the vascularized graft remains vascularized. We have a lot of vascularized bone graft where we don't know if they are after 1 month or even after some days still vascularized. So what is our aim of reconstruction? To get reunion, to get a normal form and length of the bone, and to get revascularization of the dead bone. So what did our old surgeons do when they had a non-union? And I know not Matti, but Russe, because he's the father of a colleague of me, and they invented, you know maybe that all, the Matti-Russe operation. Matti at first put it in a cancellous, cortico-cancellous bone graft from the dorsal side, and then later on Russe put that bone graft in from the volar side. But the stabilization was not very good, only with K-wires, or the first methods were without K-wires. And you see here the different methods from other colleagues here. Shanta from Hungary, I know him. He did this curved cancellous bone graft into the scaphoid along the convexity of the dorsal aspect of the scaphoid. And then 1970 Straley came and put in the first Straley screw. And you can see here the screw has a head and a thread, but it worked in some cases very fine. I was in 1975 in Straley in Linz, and I saw how he put it in his screws, and in a lot of cases it worked fine. You see here the difference between the Herbert screw with 2 threads, and the Straley screw was a little bit bigger, yeah, and disappeared from the market. Today, what do we today? The normal method is to put in waist non-unions a cancellous bone graft and a Herbert screw who hold the 2 fragments in place. But anyway, in 1974, my colleague Ender, I was in the same team, invented that Ender plate, and it was a very good method. He excavated the scaphoid like a ship and put it in a big structural bone graft from the iliac crest, and then he put over that this hook plate and gave the non-union big stability. And you see here the original drawings I did in 1981 for Ender. And this hook is a neutralization plate. It keeps the humpback deformity in position. When the humpback deformity is reduced, this plate neutralizes the power of the two fragments, and you can see it here on a clinical case. This ender plate was a little bit bulky. The screw distally was very big, but it worked. And as you can see here, between 74 and 82, I operated with him 200 scaphoids. There were 170 non-unions and 30 fresh fractures, because at that time the Herbert screw did not exist. And we had 195 unions, 5 non-unions, 5 were reoperated with the same method, and 3 healed again. And so we had a very high rate of healed scaphoids. You can see here the result from other authors. They were pretty good, but this plate, when the Herbert screw came on the market, disappeared from the market. And see here healing rates from 99, 89, 95, 95, 94%. That's pretty good. And as you know, in 1977, Herbert screw was invented by Tim Herbert. But anyway, if you have already a Herbert screw in your scaphoid and you get no union and you have a good structure in the proximal pole, then you don't need a vascularized bone graft, and I will show you later on how we do that. The concept for the reoperation depends on the fragment constitution. As I told you, you have to differentiate between structured proximal poles and fragmented proximal poles. In our house, we use more and more these 2 screws against rotational deformity and better stabilization. But anyway, also here with 2 screws, a non-union appeared, and you see here different non-unions which did not heal with screws inside. We know already that proximal pole with fragmentation cannot be healed even with any method without a non-vascularized bone graft. There is that exception, and we have questions. How can we get enough stability? How can we retain this stability over a long period? What kind of cancellous bone graft do we need? How can we control the DC deformity? And again, you know already this type of classification which leads us to non-vascularized, vascularized, non-vascularized, or osteochondral vascular bone graft. In our house, we make it a little bit easier. In the first operation, we always use the Herbert screw with a bone graft. That's our method we do in the first operation. If we have already a screw inside and we have good condition for the proximal fragment, even when we have a dense avascular proximal fragment or a gadolinium MRI verified avascular necrosis or the necrosis of the proximal pole, we go to a cancellous bone graft and a scaphoid plate. And I will show you later on how we do this method. Only in revision cases where the proximal pole is fragmented, we use a microvascular osteochondral graft. All other methods, Zeidenberg, Matulin, disappeared in our hands. That were the methods where we, before, operated this kind of non-unions or that one. But since we have this plate, we changed along to that method. The scaphoid plate we developed with Medartis. You see here different shapes. We created different shapes. The development surgeons were Dr. Martin Leixnering, Dr. Christoph Petze, and there was a design freeze in December 2010, and that plate then was launched in 2011. The scaphoid plate, you see here, a scaphoid plate on a cadaver operation, is a low profile plate from 0.8 millimeters. It has a grid structure. You can see here 2 bars. And you can put 3 locking screws in proximal and distal poles when they are big enough. But it is also enough if you have only 2 screws in the proximal pole and 2 screws in the distal pole. These locking screws give you a lot of stability, and you can screw them in different direction, 20 degrees in all directions. And you must not perforate the ada corticalis, because, as you know, locking screws give also stability without the other corticalis. The plate is pre-shaped. It should fit to your scaphoid. When it does not fit, then you have not reduced your humpback deformity. It helps to press the cancellous bone graft into the space. And sometimes, if you get here an impingement on the radius, it has to be removed. So how do we mount that plate from a volar access? Because, you know, on the dorsal side is the vascularity, and we should not impair that zone from the dorsal side. And what have we to know? The scaphoid has to be reduced from its humpback deformity through axial traction on the thumb, maximal ulnar deviation, extension of the wrist. You should extend it over a rolled towel under the wrist, and correct the DC position of lunate. I will show you some tricks later on how to do that. My colleagues, Qualbauer, Petzer, Jurkovic, Grimmer, Sauer, Bierhausen, and Leixnering published a very recent paper. You see here on the 20th December 2018 about plating for non-unions and severe fracture of the scaphoid. And that are pictures from that recent paper. We do this operation normally in general anesthesia because you have to harvest a bone graft from the iliac crest. And the arm is in supine position, tourniquet, anterior approach, that means volar approach. The capsule is incised longitudinally. Well, capsule is the wrong word. You have to go along the flexor carpi radialis, and Ender always said, go in on the radial side on the flexor carpi radialis till to the bone. And why is that so? Because you should not dissect the ligaments. I will show you that later on, because vascularity is coming from the ligaments from both sides, and so a single incision through the ligaments, the volar ligaments, which are coming here from the radius to the lunate and radius to the capitate, spares the vascularity of the ligaments. Here you see the FCR tendon, and you go really with a straight line incision. I hate these C-shaped incisions because you destroy all the vessels here around. Here is a ligamentum radius cavitatum and ligamentum radiolunatum. And you have to take care for the radial artery, because sometimes the radial artery is here going around and around the tenor to the superficial part, to the deep palmar arc, and that can lead to severe bleeding if you don't look at that branch.
Wolfgang, there's a question coming.
Yeah.
From Inga. Don't you have adhesions of FCR going so close to with capsulotomy?
Well, I have not seen that, because in most cases, we have to put out that plates, and then we see that the ligaments really heal like we were not inside. So I don't think so, that we have here adhesions. Okay, you can see here, after going on the scaphoid, the whole scaphoid, you have to see the scaphoid really till to the proximal pole. There are some exceptions when the nonunion is very wide distally. You have not to dissect the proximal ligament, only the distal ligament, but normally we dissect both ligaments, and afterwards we suture them with 2-0 with a UCL needle, a very sharp and thick needle to get the ligaments again tight over the scaphoid. That's important, because you know that ligaments support the waist of the scaphoid and bring it up in extension. You should not, you have to do suture them. So here is a maneuver, a tricky maneuver, how to reduce the humpback deformity and maybe the DC deformity. At first, you have to drill the proximal pole and put the proximal pole out of the DC position, and then we transfix through the layer radius the lunate. What does that mean? With that K-wire, you reduce already the proximal pole of the scaphoid. Sorry. The proximal pole of the scaphoid, and then you have to reduce the distal pole and maybe stabilize it intermediary with 2 longitudinal K-wires. Then you can put out the transfixing K-wire again and fill up the hole. It is very important that you bring your lunate out of the DC position. And then, when the DC is out of position and the humpback deformity is reduced, then the plate should fit on the volar aspect, and then put in 1 K-wire on the distal fragment. That K-wire is good because you see also the direction, how you should go that you don't touch your STD joint. So if you have already hardware, you should remove that hardware, then curate out the bone, really big holes. You see here the incision over the flexor carpi radialis, straight line through the ligaments till to the bone. I have to hurry up a little bit. And then here in wide exposure, at first with a drill and then with a small spoon, excavate the scaphoid, make a big hole. And what is a structural bone graft? A structural bone graft is not a bone graft in pieces, it is in one piece, and we harvested in the last time with a harvester from Artrex with a 2 centimeter incision. That's very good for the patients because they have no harm with these small pieces out. You can see it in the video with the harvester. And they fit very well in that cave. Structural expansion bigger than the hole, weaken the edges with a Lyston and put it in with a certain amount of pressure. The revascularization works linear, though it's better to make a big hole than have your earlier healing of your bone. Yeah, that means that the bone graft has to be bigger than the hole and then weaken the end. We have already seen that, how we mount that plate with angle stable screws on the scaphoid. So the indication for the plates are fresh fractures which cannot get stable with screws, multiple fragments. You can use it also for fresh fractures, non-unions with previous hardware, and large defects to gain good carpentry. That's very important. I think that's very underestimated, the good carpentry and good stability. This plate has a lot of rotational instability and can hold your reduction of the humpback deformity. Tri-lock, Waller plate placement, 2 bars in the middle for optimal stability, up to 3 tri-lock screws, proximal and distally, anatomically pre-shaped. We have already described that. Features when we don't use these plates, when you have already a snake, when you have already a radial styloid arthritis, scaphocapitate arthritis, or general arthritis, then you have to do a salvage procedure or a couple fusion. So one case, a simple fracture of the waist, treated at first conservatively. You see here in the primary X-ray, it looks, yeah, not so bad, but if you see the oblique fracture, you see a wedge fragment, and that cannot be done conservatively. And the surgeon, look at the timeline in 2010, the 2 weeks later, they operated the scaphoid and put it in a screw. The screw was not very good, and you can see here in 2010, after 1 year, a non-union appeared. And that's really the indication. If you have a big hole, a screw who does not hold again, and they have resorption zone, and again a screw is not the right method for that. Then they did further operation for the non-union cancellous bone graft with a K-wire. How should that work? They have no stability, and it happened what has to be happened, a non-union again. Now look at the timeline, we are in 2011, and that is a mess. And then we put it in that Medartis scaphoid plate with a big cancellous bone graft. Yeah, I see here some question. Is a cast not necessary after suturing the ligaments? I say, after putting in the plate, yes, we fix them with the cast for maybe 4 to 6 weeks. Yeah, and the ligaments can heal. And you see here 2009, 2012, and then here the scaphoid non-union healed. And after removing the plate, you have here some exostosis, and sometimes when you remove the plate, you can also put out that exostosis, because dorsal extension sometimes is blocked by this dorsal exostosis. But you see here a good movement. I was in Amsterdam last week, and the chair of this symposium was Pascal Hannemann. He has a lot of experience, and he published also this paper with angular stable mini plate fixation of chronic unstable scaphoid nonunion. Is it the future? And you see here he had patients with 8 from 15 with previous surgery, and 3 from 15 had an avascular proximal pole, a clear indication for a vascularized bone graft or not. He did only that what we do too, a plating with a structural and bone graft, and you see here 93% healed, and time to union was 5 months in the middle. A very good result. And you see here the range of motion pre and post-operative. And so as a conclusion, locked volar plating of scaphoid with segmental defects allows a physiological superior cancellous graft to be used without concerns to structural compromise, because you have not to put the screw through the structural, the middle is spared out from the plate. And locked volar plate fixation with cancellous bone graft compare favorably to previous reports of more traditional techniques that involve vascularized or non-vascularized corticocancellous grafting. And scaphoid nonunions with segmental defects treated with volar locking plating and cancellous grafting will heal faster than other more traditional techniques with comparable or better functional outcome. That's not my conclusion, that's a conclusion from Scott Edwards, treating scaphoid nonunions with plate fixation and cancellous grafting. But we all together think that this plate has really hand down the vascularized bone grafts, which are not necessary, I think, in the most of cases which were previously were operated with a vascularized bone graft. Well, on the end, are there questions for the operation method or for the plate or something else? Well, if there are no questions, do we have time for a case or not?
We still have a little time in case you want to show. We're very welcome.
I will show you one case which is interesting maybe, because you see here the non-union with the screw inside. It is like one of the other cases. In the next, we see here it was plated with a cancellous bone graft, and it healed with the plate. But what you see is the dorsal, the dorsal hump. It has no humpback deformity, but from the healing, it gets a hump here on the dorsal side. And the patient was a young quarterback, and he suffered with dorsal extension, and he said, oh, well, can you make that better? And I put it out his plate. You can see a 3-dimensional view, and it's sometimes it's a little bit tricky to get out these screws. You see here in the non-union the screw shining out, and then you have to detect on the X-ray intensifier the head of the screw, put in a K-wire and take it out. This can take sometimes an hour or more. And then I excavated the whole scaphoid as I described it. And you see here such a big structural bone graft. I weaken the ends only with a Lyston and then pump it in under with big power, and it expands under the edges of your cavity. And you see here, when the structural bone graft is inside, you have almost already the stability to move your 2 poles without any possibility for a humpback. Then that was the revision operation on the dorsal side. And you see here clearly that exostosis here, yeah, which impinged on the dorsal end of the radius. You can imagine when he extends, that bone comes to here. And then I took away that hump here. And you see here then after removing this hump, the full length, the really nice shaped scaphoid. You see here the holes from the plate. And yeah, the patient was very fine and could extend his wrist to 70, 80 degrees. Okay, any questions? Ja, bei sehr proximal pole wollen Sie proximal pole fractures, would you do an arthroscopy preoperatively? Good question. Well, there are some guys who treat nonunions arthroscopically. Yeah, they drill out the nonunion and then put over canal cancellous bone graft in and do a stabilization with K-wires. I saw a presentation here in Amsterdam. I don't do that. Yeah, I think there you have to be a very good arthroscopic guy to do that procedures. And yes, for diagnosis only, I think we have a lot of tool not to look in the joint. So I don't do it. Well, I think we are on the end. It is 1 minute to 22 p.m. And I thank you all for your participation and for your questions and wish you a good evening. Thank you very much.